Welcome to Hersing University NU 640 Introduction to Women's Health Across the Lifespan. This video will discuss Chapter 30 from your Alexander and Colleagues textbook, as well as Chapter 22 from your Sarkio and Sikor text. This discussion will serve as a brief overview of the material. Therefore, I would like to ask that you please read the chapter for additional and required information. Additionally, I would like for you to review all other required and supplemental resources. This presentation will be represented by myself and Dr. Alicia Sutton. Prompt diagnosis and treatment are predicated on the assumption that any person who believes he or she may have contracted an STI, has symptoms of an STI, has had sexual relations with someone who has symptoms of an STI, or has a partner who has been diagnosed with an STI will seek care. To obtain prompt diagnosis and treatment, patient must know how to recognize the major symptoms and signs of all STIs and must be willing and able to obtain health care if they experience symptoms or have sexual contact with someone who has an STI. You have the responsibility of educating your patients regarding the signs and symptoms of STIs. This may be done when a woman comes in for her annual health exam, seeks contraception, or obtains preconception or prenatal care. You also must ensure that patients know where and how to obtain care if they suspect they might have contracted an STI.
Current recommendations are that all women from age of first sexual act until age 25 years, they should be screened at least yearly for STDs. After the age of 25, the timing and screening depends on risk factors present and whether the woman is pregnant. Furthermore, any woman who has been diagnosed with an STD should be screened for other STDs because many of the infections can be asymptomatic in women. And all pregnant women must be screened for gonorrhea, syphilis, chlamydia, HIV, and HBV. We will discuss the most common STIs in women, including cervicitis, which includes chlamydia and gonorrhea, pelvic inflammatory disease or PID, and ulcerative genital infections such as syphilis, genital herpes simplex, and chancroid. In a separate lecture, we will discuss diseases characterized by vaginal discharge and hepatitis. Chlamydia or non-gonococcal urethritis is the most common STD in the United States, with the highest prevalence being among persons 24 years and younger. Risk factors for this infection include multiple sexual partners and failure to use barrier methods of contraception. Serious complications of chlamydial infections can occur, including PID, ectopic pregnancy, chronic pelvic pain, and infertility. Recommended screening procedures for chlamydial infection in women is by testing first catch urine or collecting swab specimens from the endocervix or vagina. Now, the CDC has expanded recommendations among asymptomatic women. They state that all sexually active women aged 25 years and younger should be screened for chlamydia annually. And women older than 25 years with risk factors, such as new or multiple partners, should also be screened. So it is important to note that a lot of women will be asymptomatic. They will not even be aware they have an infection. However, women experiencing symptoms may report spotting or postcoital bleeding, mucoid or purulent cervical discharge, urinary frequency, dysuria, lower abdominal pain, or dyspareunia. Bleeding will result from inflammation and erosion of the cervical columnar epithelium. Physical exam findings of guarding, referred pain, or rebound upon abdominal examination should raise your suspicion for PID. Cervical friability may be detected with the speculum exam, and discharge, if present, is characteristically mucopurulent. During the bimanual exam, a woman may report pain with cervical movement, and you may note adnexal fullness and uterine tenderness. Again, these findings are also suggestive of PID. Upon microscopic exam, you are going to see a lot of white blood cells.
Recommended treatment for chlamydial infections is doxycycline 100 milligrams by mouth twice a day for 7 days. Alternative regimens include azithromycin 1 gram orally in a single dose, or levofloxacin 500 milligrams orally once a day for 7 days. I want to draw your attention to the chart that is displayed. This data is taken from the CDC Guideline Pocket Guides located in the Supplemental Resources module. I encourage you to download and use these resources in clinic and practice.
Next, we're going to discuss gonorrhea, as it is the second most commonly reported bacterial STD after chlamydia. Gonorrhea is almost exclusively transmitted by sexual activity, primarily through genital to genital contact. However, it is also spread through oral to genital and anal to genital contact. Sites of infection in females include cervix, urethra, oropharynx, Skene's glands, and the Bartholin's glands. In addition to age, other risk factors for this infection include early onset of sexual activity and multiple sexual partners. Now, the main complication of gonorrhea infections is PID. Women may also develop a pelvic abscess or Bartholin's abscess. Women with gonorrhea often remain asymptomatic. However, when symptoms are present, they are often less specific than the symptoms in men. Women may report dyspareunia, a change in vaginal discharge, unilateral labial pain and swelling, or lower abdominal discomfort. Now, later in the infection's course, women may describe a history of purulent, irritating vaginal discharge or rectal pain and discharge. Menstrual irregularities may be the presenting symptoms, with longer, more painful menses being noted. Women may also report chronic or acute lower abdominal pain. Unilateral labial pain and swelling can indicate a Bartholin's gland infection, and periurethral pain and swelling may indicate inflamed Skene's glands. Now, infrequently, dysuria, vague abdominal pain, and low backache will prompt a woman to seek care. Later symptoms can include fever, nausea, vomiting, joint pain and swelling, or upper abdominal pain, which would indicate liver involvement. Physical examination will be individualized based on the woman's presenting symptoms. So, obtain vital signs and perform a general skin inspection for signs of classic DGI lesions, which are painful necrotic pustules on an erythematous base. Inspect the pharynx and oral cavity for erythema, edema, and lesions. Assess for cervical lymphadenopathy. Palpate the abdomen for masses, tenderness, and rebound tenderness. And during the speculum exam, inspect the vaginal walls for discharge and redness, and examine the cervix for mucopurulent discharge, ectopy, and friability. During the bimanual exam, you're going to want to observe for cervical motion tenderness, uterine tenderness, adnexal tenderness, and adnexal masses, which are all findings associated with PID.
It is important to note that all patients with gonorrhea should be tested for other STIs, including chlamydia, syphilis, and HIV. Management of gonorrhea is straightforward, and the cure is usually rapid with appropriate antibiotic therapy. Single-dose efficacy is a major consideration in selecting an antibiotic regimen for women with gonorrhea. Another important consideration is the high percentage of women with coexisting chlamydial infections. The CDC suggests concomitant treatment for chlamydia because, remember, chlamydia follows gonorrhea. Ceftriaxone 500 milligrams intramuscularly in a single dose plus doxycycline 100 milligrams twice a day for 7 days orally is preferred. It is crucial to educate patients to abstain from sexual relations for the 7 days after therapy is initiated.
Moving on to pelvic inflammatory disease, or PID. So multiple organisms have been found to cause PID, and most cases are associated with infection by more than one organism. So there's a wide variety of anaerobic and aerobic microorganisms, including some found in the vaginal flora, that is associated with PID. Adolescents are at greatest risk. Other risk factors include multiple sexual partners, a history of STDs, cigarette smoking, and douching. The infection can be acute, subacute, or chronic, and may be associated with a wide range of symptoms. Diagnosis is difficult because almost all of the most common signs and symptoms could accompany other urinary, GI, or GYN problems. Therefore, accurate and prompt diagnosis is crucial to minimize the long-term complications of this. The severity and extent of symptoms that women with PID experience can vary widely. It's what makes it so difficult, but commonly reported symptoms include abdominal, pelvic, and lower back pain, abnormal vaginal discharge, intermenstrual or postcoital bleeding, fever, nausea, vomiting, and urinary frequency. Women may report levels of pain ranging from minimal discomfort to dull, crampy, and intermittent pain to severe, persistent, and incapacitating pain. Pelvic pain is usually exacerbated by the Valsalva maneuver, intercourse, or any movement. As part of the assessment for PID, fever may be present. However, the majority of women will not have one. Physical exam may reveal adnexal tenderness, abdominal tenderness, uterine tenderness, and tenderness with cervical movement. Pelvic tenderness is usually bilateral and there may be a palpable adnexal swelling or thickening.
As we have discussed several times, the most important approach to management is primary prevention through education, such as avoiding STIs. Secondary prevention involves the prompt treatment of lower genital tract infections to prevent the infection from migrating to the upper genital tract. In the past, all patients were hospitalized. However, research no longer supports this. Therefore, you will want to follow the CDC's guidelines regarding the need for hospitalization. A broad-spectrum antibiotic is generally administered. Several regimens have proven to be effective, and no single therapeutic regimen appears to be superior to others. You should consider analgesics for pain and other comfort measures.